Hello, I'm Dr. Kathleen Moore from the Stevenson Cancer Center in Oklahoma City, and it's my great honor to have been invited to speak at the Basser Symposium. And today I'm going to spend just really a brief amount of time talking about how PARP inhibitors have really revolutionized the treatment of women with BRCA-associated epithelial ovarian cancer and kind of the challenges use of PARP inhibitors have brought to us that we're going to have to address moving into the future. These are my disclosures that I'll leave up for a moment. So what I hope to cover today is really just to give a review of the current status of PARP inhibitor use in BRCA-associated epithelial ovarian cancer. I'm going to very briefly touch on the role of immunotherapy in this particular subgroup and overall, and then really just start to give a couple examples of how we are thinking about overcoming acquired or even de novo PARP resistance in epithelial ovarian cancer. And so I want to start, just because I know we have a broad audience, of just level setting with what we can expect in frontline advanced ovarian cancer, epithelial ovarian cancer, with platinum-based chemotherapy alone. And so what I'm showing you here is the progression-free survival curve from ICON 8. I don't really want to get into ICON 8 too much other than to say it is the most recent and probably the last large phase 3 trial that will be done in epithelial ovarian cancer without a biologic and really without any sort of stratification by BRCA or homologous recombination deficiency status. So it was purely an all-comer study looking at different ways of sequencing paclitaxel and carboplatin, clearly with no difference. But the point of this slide is really to show you what the PFS curve looks like when we use chemotherapy alone. And point one is that it hasn't changed much in the past few decades since paclitaxel and carboplatin has been the standard of care. Point two, if you look at the upper left part of this curve, what you see is what we refer to as the shoulder. And this shoulder, again, has been frustratingly consistent across the decades and represents about 20% of women who recur within 6 months of completing first-line platinum-based chemotherapy, putting them into this prognostic group called primary platinum-resistant disease, which despite a lot of effort, we have not been able to move the needle on in a long time. So we want to avoid this group, avoid placing patients in this group with by whatever means necessary. And then the third important point is that by 3 years, approximately 80% of women with advanced ovarian cancer will have recurred. And because of clinical trials and better supportive care, we have more women living with their disease right now than ever in the past. Our prevalence is the highest it's ever been. But these are women living with disease. It is no longer curable. And so if we are going to improve the fraction of women who are long-term disease-free survivors, it has to be in the front line. We had a little bit of, if you like a sports analogy, a base hit with bevacizumab. These are not new studies. This is GOG 218 and ICON 7. These were done about a decade ago, and they did lead to, in the United States, a standard of care, an option. In many parts of the globe, it is the standard of care to use bevacizumab in the front line, and in fact, it's the only place they can use bevacizumab. So globally, use of bevacizumab does vary, but this is what you get. Hazard ratios are 0.7 to 0.8, and so that translates into a 20 to 30% reduction in the risk of progression or death with the use of bevacizumab with and to follow chemotherapy. So a clinically and statistically important and significant improvement in the progression-free survival, but we still have that shoulder and we still have women recurring. And again, these studies were done prior to our understanding of the importance of stratification and addressing those women with BRCA mutations, other homologous or other DNA repaired gene mutations, and the homologous recombination deficiency state. And so PARP inhibitors really have been transformational here for women with epithelial ovarian cancer, specifically those with BRCA-associated cancers, as you can see here. These are the 3 big studies that led to new indications. First, SOLO-1, presented in 2018, and then PRIMA and PAOLA presented in 2019, which led to FDA approvals for monotherapy switch maintenance or concomitant bevacizumab and olaparib in women with either BRCA and or homologous recombination deficient tumors. And the hazard ratios here are striking, 0.3 to 0.4. So a 60 to 70% reduction in the risk of hazard or death, in the risk of progression or death with incorporation of a Parp inhibitor. And for SOLO-1, where we have the longest follow-up to date, we're now over 5 years. At the 5-year point, we have about 50% of women randomized to olaparib still disease-free, and we hope many of those will remain so, and we will really be able to show an improvement in overall survival. What role does immunotherapy have, either by itself or with Parp inhibitors? That's sort of the next big question. And unfortunately, it's been a little bit of a disappointing journey for us. We have two big, several thousand patients trials that evaluated incorporation of immune checkpoint inhibitors into the frontline treatment paradigm. This is Javelin 100, led by Jonathan Letterman, which incorporated, kind of like bevacizumab, the checkpoint inhibitor avelumab, either with chemo alone, with chemo and to follow, or versus placebo. And this was stopped early because it was clear that it wasn't going to benefit, but there was also, if you see in the gold line, which is the chemo followed by avelumab, the patients actually looked like they were trending towards doing worse as compared to placebo. And so this was highly concerning. We were very hopeful about the Imagine 50 study, which was similar, was women with advanced stage epithelial ovarian cancer, all comers who had paclitaxel, carboplatin, bevacizumab, plus or minus the immune checkpoint inhibitor atezolizumab, stratified by PD-L1 positivity status. And so we felt like, or we hoped, that this would be the difference, really building on the nice preclinical data, admittedly in other tumors, of synergy between anti-angiogenic agents and immune checkpoint inhibitors. But that did not play out here. As you can see, we didn't harm people, but there was really a clinically insignificant bump in the progression-free survival in both subgroups, neither of which warranted a new indication, which really kind of brings the question up, why? Why has immune checkpoint inhibitors been thus far really only modestly to really not active in this patient population? Now, Imagine 50, we did not stratify by BRCA or homologous recombination deficiency status, but we did look at it in an exploratory fashion. And I think this is telling. What we can see here is that unlike prior data, there have been some reports now kind of old, 5 to 7 years ago, that suggested women with BRCA-associated cancers would have more neoantigens and they would be more likely to respond to these immune checkpoint inhibitors. And so we thought, well, maybe in Imagine 50, we look at these patients, these are the ones that are really going to have done well. And so there's a lot of translational work coming out of this big study, but this is really just showing you how little we knew, and we really need to understand this moving forward about ovarian cancer, even amongst those women with BRCA-associated cancers. Tumor mutation burden is low, and it's low whether or not you're a BRCA carrier. And that's what's shown here. And also on the right-hand side, you can just see homologous recombination status. There was no difference there either. So this sort of enrichment in a BRCA-associated cancer that we were hoping for in some of the biomarkers that might portend a better response to immune therapy, really, when we look at it in large samples, doesn't seem to be true. Now, when we look at outcomes from this study by BRCA mutation, of course, BRCA mutations are associated with a better PFS when patients receive carboplatin, paclitaxel, and bevacizumab, but we knew that. But it's not a population that's enriched by PD-L1 positive tumors. In other words, we aren't seeing more of these biomarker positive tumors in the BRCA population. So it's not tumor mutation burden, and it also doesn't seem to be PD-L1 status. And when we look at just these subgroup analyses, we really don't see any association between BRCA status and atezolizumab plus chemotherapy clinical outcomes, no matter how you slice it. by BRCA and having immune cells that are positive, BRCA, and tumor cells that are positive for PD-L1. None of this even gave us a signal that BRCA is an important biomarker for response to immune therapy. So at least for now, these would be considered mostly negative studies from which we need to build. And build we will. These are the 4 studies that are largely accrued. One of them is just finishing their accrual. The other 3 are all accrued. The ones in the red have a Parp inhibitor plus an immune checkpoint inhibitor plus bevacizumab, so triplet therapy. And the one that I don't have outlined is the Athena study, which is really asking a true switch maintenance question. There's no bevacizumab here, of adding rucaparib to nivolumab versus rucaparib alone. And that study was the first to complete accrual, and we anticipate the first to read out. And so we are expecting some readout on it potentially this year. So there is quite a bit of data coming. Hopefully some will be positive, and we'll learn quite a bit as these studies start to result. And so, you know, the paradigm changes in the front line for ovarian cancer, certainly for those with BRCA cancers, but really overall, where we have the option to use Parp inhibitors in everyone. We have the option to use bevacizumab and a Parp inhibitor in anyone who has a homologous recombination deficient tumor, which of course includes BRCA. And so there is this increasing trend towards using Parp inhibitors in everybody, and potentially Parp and bevacizumab. And so if we're using all of our best agents up front, what do we do here? Because although I do believe a fraction of patients in SOLO-1 have been cured, and I anticipate it's going to be a large fraction, you can see from those survival curves that women have recurred. And will likely continue to recur. And they will be platinum sensitive because they've gotten a Parp and their BRCA. And this is true for other patients as well who have received maintenance. They're much more likely to be platinum sensitive just by virtue of that timeline definition being more than 6 months from your last platinum. And so, you know, here in the second line, of course, we would retreat them with a platinum-based doublet. But what do we do as a maintenance if we've already used things kind of up front? Well, of course, we have bevacizumab, and we know you can use, at least in the United States, we can use bevacizumab again. We have some suggestion here in the boxed 2 studies, GOG 213 and AGO-OVAR 2.21, that there's a modest survival advantage to using chemo plus bevacizumab and bevacizumab maintenance to recurrence in this largely first, but sometimes second platinum sensitive recurrence. And we have data with retreatment as well that it's still effective. So this is certainly an option. Whether or not it's our best option remains to be seen, but certainly an option, especially for a patient that did not receive bevacizumab in the front line. And then we have all of the data from really the first indications for Parp inhibitors, which were the platinum sensitive recurrent setting. Here divided, the 3 big studies, of course, were SOLO-2, NOVA, and Ariel, which showed benefit in all patients, irrespective of molecular biomarker, really because they all had to have responded to that penultimate platinum. And that clinical biomarker was probably the most important thing for identifying women who would benefit from a Parp. So the amount of benefit is a gradiated benefit, with the best being amongst those with BRCA associated cancers, and I have them in boxes here with hazard ratios that are remarkable, 0.2 to 0.27, even better than the front line, although that does not mean that this is the place where you wait to use them. Really, you just have both the molecular and the clinical biomarker of response to platinum kind of leading you to this. So this was really where we got our first indications for Parp inhibitors from phase 3 studies, but all of these studies were done in Parp naive tumors. And so how relevant is this data now? If certainly all patients with BRCA will likely have been treated already with a Parp inhibitor. So we are going to answer this question potentially with the OREO study, which is olaparib retreatment. It's not a super sexy study, but really it's asking the question, If you've received a PARP in the past and you have platinum-sensitive recurrent disease and you respond to that platinum, again, that clinical biomarker is key, you're then randomized to olaparib or placebo and stratified by BRCA status, as you can see here. And they're going to be looking at the progression-free survival is the primary endpoint, and the overall survival are the secondary endpoints. Now, I believe this has completed accrual, and so we'll be waiting for this, this output in the next 1 to 2 years as well. So again, an incredibly important study because these patients are already here. They're already presenting. They've received a PARP potentially on a clinical trial in the past. A lot of medical oncologists were very forward-thinking and were getting these patients on PARP even before SOLO-1 resulted. So there's a lot of women out there who have a BRCA mutation, and of course, many more who don't, who've seen a PARP, they've responded again to platinum, and can you use a PARP again? We don't know. So this is a really hot topic and requires an answer. So the third place where we're using PARP inhibitors, or the idea is, can we replace chemotherapy with a PARP inhibitor? And this really comes from the very first indications for PARP inhibitors, which were accelerated approvals. Dr. Kaufman, who's here at this conference, of course, led the way with what was Study 42, but now has been renamed Study 1 for olaparib. That got us our first indication in women with BRCA-associated cancers, 3 or more lines of therapy with a very respectable 34% response rate. Ariel 2 went, in Study 10, went 1 line earlier. Oops, sorry about that. For 2 or more lines of therapy, BRCA associated. And then Quadra was a little bit different, was 4th line and beyond, 29% response rate. So this gave us the idea that maybe we could replace chemotherapy with a PARP. Well, you know, really to prove that, you got to compare. So we have 3 studies now comparing replacing chemotherapy with a PARP inhibitor. Solo 3 and Ariel 4 were both done only in women with BRCA-associated cancers. Monotherapy PARP versus investigator's choice chemotherapy. And so the middle row is BRCA mutated, and that's the only patients who are eligible. So you can see the hazard ratios here in favor of PARP inhibitor in this population were 0.62 and 0.67, very similar. So over investigator's choice chemotherapy, Solo 2 or 3, I'm sorry, didn't allow a platinum, even though this was a platinum sensitive population. So that's one criticism. And Ariel 4 allowed platinum resistant and platinum sensitive, and they haven't quite teased out those different groups. So we still have something to learn from those 2 studies. GY004, led by Joyce Liu from Dana-Farber, was sort of our big attempt to compare olaparib to paclitaxel and carboplatin in the platinum sensitive setting. And so this was an all-comer study, but did include a good number of women with BRCA-associated cancers, and there was no statistical benefit to using a PARP or PARP cediranib over chemotherapy, although the numbers were quite small. But the issue here is that the standard of care changed during the course of the study. The comparator was paclitaxel and carboplatin for 6 cycles and stopped versus olaparib forever. And of course, now in a BRCA-associated cancer, you wouldn't consider that to be ethical. You would use paclitaxel carboplatin with a PARP maintenance in a PARP-naive population. And so that study is really limited, unfortunately, by the big change in the standard of care, making it a little bit uninterpretable. And again, these were all in PARP-naive patients. And so does this population even really exist anymore? Will it exist moving forward? Probably not. You're not going to see a 4th-line BRCA-associated cancer who's not had a PARP. And so really what we're going to need to figure out now, because all of these women, hopefully some are cured, a lot, but a lot of these patients will present to us with progression, either platinum-resistant disease or progression on a PARP. So PARP-resistant disease. We are charged with developing therapies that will hopefully restore their homologous recombination deficient status, if indeed they have acquired a homologous recombination proficient status by a number of mechanisms. And those are highlighted here in the red box. So restoration of homologous recombination activity can either be indirect, and we'll give a couple examples of that, kind of alternative pathways that restore homologous recombination proficiency, or direct in this green box, where basically you have a reversion mutation in your BRCA or RAD51 gene mutation that restores a reading frame as you have a normal functioning gene, or demethylation of a BRCA1 promoter methylation that again restores normal reading of that protein. So are these things that we need to be worried about, and can we address them? Yes, and I hope so. We've known about reversion mutations for a long time. This is Barbara Norquist's work from University of Washington from a decade ago. And what she looked at here was a retrospective group of women with BRCA-associated cancers who were either platinum resistant or platinum sensitive, and looked for these reversion mutations and found that they were highly correlated with development of platinum resistance. And this is in a pre-PARP era. So these are BRCA1 or 2 reversions that occur on platinum. And we now are increasingly understanding that that happens. So they're not only associated with lack of response to platinum, but also to PARP. So this is from the Ariel 2 study. And so women that were coming on this study could be platinum resistant or platinum sensitive, and they had pre-PARP translational work done, which is what you're seeing here. And at the bottom of this figure, those green bars are all of the identified samples that have a reversion mutation. And at the top, what you can see are the platinum-free intervals for the women who are entering Ariel 2. So on the right-hand side, these are the platinum-sensitive patients. On the left-hand side, these are the platinum-refractory and resistant tumors. And you can see how correlated reversion mutations are with women coming onto Ariel 2 with resistant tumors, again, by virtue of platinum exposure. But these reversion mutations also predict or negative predictive biomarkers for response to PARP. And so you can see here that patients with reversion mutations identified in their pretreatment DNA had much shorter, those are in red on the PFS curves, much shorter progression-free survival curves than their counterparts who had intact BRCA mutations. Whether or not they're platinum resistant or platinum sensitive, they still responded for the most part to the Parp inhibitor, whereas those with reversion mutations did not. And in the lower waterfall figure, I know it's small, but you can see the little dots that are on mainly on the left-hand side, and the patients who didn't benefit, those little dots on top of each of those bars indicate a reversion mutation. So they're highly skewed towards patients who did not get a benefit from the PARP. And now we've seen this again in Ariel 4, which I've already talked to you about, which was platinum sensitive or platinum resistant BRCA associated cancers who were being treated with either rucaparib or investigator's choice chemotherapy. In blue are the patients who received rucaparib, and in orange are chemotherapy. And these are all the patients with identified reversion mutations who did very poorly if they were randomized to PARP. The chemotherapy group actually did better, which really brings up the importance of knowing this if we're going to enroll women onto a clinical trial with a Parp inhibitor or treat them with a Parp inhibitor, because this does appear to be a very strong negative predictive biomarker for response, at least to monotherapy Parp. So reversion mutations are becoming, well, they are incredibly important. We're understanding that clinically, but we're actually understanding more about them. And it's more than just you have a reversion mutation or you don't. And so this is a really recent review article by Tobolina et al. That I could honestly talk for hours about. It's a fascinating paper, and I would encourage you to take a look at it. But I'm putting up one of the figures just to give you a sense of what this paper contains. But the main points I wanted to make about this is that what they bring up is that the prevalence of deletions as the main mechanism of acquisition of reversion mutations in BRCA genes would suggest the presence of a DNA double-strand break intermediate that's repaired by end joining mechanisms. And so you see two signatures of these end joining mechanisms that potentially we can target to overcome these reversions. The first is non-homologous end joining. And so you can identify these by these mutational signatures that involve generation of small indels. And you'll see these, not entirely, but you'll see them enriched in these secondary mutations affecting BRCA2 and acquired during treatment to PARP rather than during treatment of platinum induced reversion mutations. So that's interesting. And non-homologous end joining may be a mechanism that we can target with DNA PK inhibitors, which are currently in the clinic. And so this is one exciting opportunity. But probably the bigger opportunity comes with what are called Mmej signatures. And so Mmej repair involves more extensive DNA end resection and what are called use of microhomologies, which flank each break site of the DNA. And so you observe, this paper commented on the fact that they observed this microhomology use, or these microhomology signatures, regardless of the therapeutic regimen that led to the alteration in the gene. So either on a Parp inhibitor or on platinum, they were seeing these microhomology signatures suggestive that Mmej repair mechanisms may be responsible for the reversion mutations. And so this is important to know because one of the key players in Mmej repair is DNA pol theta. And this has been known for a long time, but what's exciting now is that there are pol theta inhibitors entering the clinic. And they're not quite in the clinic yet, so it's not in the public domain, but they're coming with great purpose in terms of either overcoming resistances or preventing resistances. So keep your eyes out for these pol theta inhibitors and the clinical trials coming. These are very exciting and exactly what we need to be doing to address this issue, this very important issue of development of reversion mutations. So I've talked a little bit about the direct restoration of homologous recombination repair activity. How about indirect? And so there's multiple ways that cells, and we know this, figure out ways to overcome whatever you're throwing at them. And so when you're talking about ovarian cancer cells, they can restore their homologous recombination proficiency through upregulation of vascular epithelial growth factor, EGFR, MET, loss of 53BP1, downregulation of shieldin proteins, which you can pick up by P10, all sorts of things. And there's just not enough time to go through all of the examples, but I'm going to give you one or two. So the first one that we've studied the most is this idea of combining Parp inhibition with anti-angiogenic agents. And so this comes from a lot of people's work. I'm showing you something that's shared with me by Dr. Tim Yap from MD Anderson, really that kind of set the stage for combining Parp and anti-angiogenic agents, because inhibition of vascular epithelial growth factor, we think, or we know actually, downregulates the hypoxia-induced homologous recombination repair, specifically in ovarian cancer cells. And so this has been shown many times preclinically, and we have many clinical trials actually that show this, but further preclinical work points to VEGF is important, but the PDGFR beta is actually maybe more important in this inhibition of homologous recombination, hypoxia-induced homologous recombination repair. And so that led to the study by, again, Joyce Liu and others of olaparib and cediranib. There have been studies of olaparib and bevacizumab, all demonstrating some synergy, especially in patients who are BRCA wild type, but all in PARP naive patients. And so Stephanie LaRue from Princess Margaret asked a very important question. Well, if you inhibit homologous recombination proteins, can you overcome someone who has PARP resistance? Can you restore the homologous recombination deficient status with this combination? And so this is the EVOLVE study, and this was just published in CCR. Again, it's really beautiful. I would encourage you to take a look at it. But what she did is, in this small study, she enrolled women who had progressed on their last PARP, and they could be PARP sensitive or platinum sensitive, platinum resistant. And then there was an exploratory cohort of patients who had progressed on a PARP at some point, but maybe not their immediate past line of therapy. And they were given olaparib and cediranib. They had archival biopsies, pre-treatment biopsies, and they looked at responses, which were few. But importantly, what she found on the pre-treatment biopsies were a large number of reversion mutations. 5 patients had reversion mutations in BRCA, 1 in RAD51. We had RAD51 overexpression, RAD51C overexpression in baseline samples. And this is important because, again, preclinical evidence would show that RAD51C deficient cancer cells are sensitive to Parp inhibition, and loss of RAD51C promoter hypermethylation may lead to Parp resistance. And so this is interesting that we're seeing more RAD51C here on post-Parp and Parp resistant samples. None of these changes could be overcome by adding cediranib to olaparib. The other interesting thing that she found was, and we've known this, but now we're showing it, that these patients, many of whom had BRCA mutations, developed CCNE1 amplification on their post-PARP samples. And so we think of these as mutually exclusive molecular events at baseline. But after time and developing PARP resistance, there's development of CCNE1, and CCNE1 amplification or copy number gain potentially are potential biomarkers for use of some of our replication stress agents. So really identifying the right patients may have just gotten more challenging. So I would encourage you to take a look at this, because it unfortunately doesn't appear that this combination is going to solve our problems. But this one might, and so this is really interesting. This is use of a PI3 kinase inhibitor with a Parp inhibitor to really sensitize and promote a homologous recombination deficient status, irrespective of whether or not you have a PI3 kinase pathway mutation. This is a metabolic intervention, and this development has been led a lot by Dr. Gerberg-Wolf and Panos Konstantinopoulos and others. But what mechanistically you see is downregulation of BRCA1 and 2 appears to be mediated by ERK-dependent activation of this ETS1 transcription factor, which then suppresses BRCA1/2 gene transcription and leads to deficient homologous recombination repair and PARP sensitivity. In addition to this, the DNA damage induced by PI3 kinase inhibition may also be a consequence of impaired production of nucleotides. So it reduces the nucleotide pool. So there's two mechanisms of action here. Dr. Konstantinopoulos has studied this in a phase 1, and I'm showing you the results on the left. These are platinum-resistant patients, almost all of whom had some reduction in their rhesus measurements, which is quite remarkable. And it was irrespective, again, of PI3 kinase mutations. And this has moved into an ongoing randomized study called EPIC-O. Many of you may have this open, of olaparib and alpelisib versus investigator's choice chemotherapy in BRCA wild-type platinum-resistant ovarian cancer that allows prior PARP. Now, more exciting to me and to many of us is a similar study using copanlisib and olaparib versus investigator's choice chemotherapy only in women who have progressed through a prior PARP. So here it does include women with BRCA-associated cancers. This is moving through the NCI and the NCTN, and it's close to final approval, and so is based on the great work that has been done by Panos and his team. So this is pretty exciting. So there's many other examples I could give of how we are trying to restore homologous recombination deficiency. But in the interest of time, I just want to focus on some of the other strategies, which is really focusing on mitigation of replication stress. And so when we talk about mitigation of replication stress, really there's many ways to come at it, but the one with the most sort of inertia right now is coming at Atr inhibition. To remind you, Atr, when activated by replication stress, will stabilize our replication forks and activate the S and G2M checkpoint. So this allows for repair of damaged DNA. In cancers with increased levels of replication stress, Atr inhibition will lead to replication fork collapse and loss of the G2M checkpoint, which allows damaged cells to enter the mitotic phase and lead to mitotic catastrophe and cell death. So very high priority mechanism. And because of that, there's a lot of these in development. This slide is already out of date, unfortunately, but there's 3, all of which are in phase 1 and 2 testing. There's some actually that are just entering phase 1. So this is an area of high interest. But how do we use it? I think is where we're still kind of struggling. There's data for monotherapy use where, it's a little bit active, mainly only in patients with loss of ATM. which isn't super common, and we aren't seeing really big durable responses. And so monotherapy probably isn't where it's at. But really in combinations, the preclinical data would tell us is where we need to be. And so what we know about PARP inhibition, there's many combinations. I'm going to give you one example. PARP inhibition, we know, impairs single-strand breaks, leads to double-strand breaks that are repaired by homologous recombination, and it has a whole bunch of other functions as well in the homologous recombination repair pathway. But PARP is also involved in ligating lagging strands of Okazaki fragments within the replication fork and promotes fork stability. So PARP protein has a role in both. And so PARP combined with ATR inhibition, which induces replication stress, synergistically should increase apoptosis and cause tumor regression. And we're showing this on the right-hand panel. These are xenograft models, all in PARP-resistant models. And the combination is what you see in purple. And so there's incredible synergy of PARP and ATR, PARP's in blue, in those middle, in the middle column, and ATR's in red, and purple is the combination in PARP-resistant models. Incredible synergy. And so why is this? And why is it important in a PARP-resistant model? Maybe a reversion mutation for BRCA. So we know that the protein domains of BRCA1 and 2 play different functions or important roles in both, just like PARP, in the homologous recombination and the replication stress pathway in preserving genomic stability. So PARP-resistant tumors those that express hypomorphic forms of BRCA proteins, could benefit from these combinations of other targeted agents. For example, you have the RAD51 binding region in BRCA2, you have isomerization of the ring domain of BRCA1. These are required for their function in the DNA replication fork protection, but not in homologous recombination repair. And so this would suggest that reversions affecting the functionality of these regions could be targeted by agents that cause replication stress. So even though there's a mutation that has led to homologous recombination proficiency, a reversion mutation, we still may have the ability to be synergistic in terms of replication stress with these combinations. So that's where this excitement really comes from. And we've seen it already that we can do it. This is the clinical trial, again, that Tim Yap ran, giving us a recommended phase 2 dose of the two agents. The problem here is that we kind of learn as we go. And the strategy of trying to maintain the PARP at the highest level and bring the ATR up to as much as you could with the PARP at full level may have been the wrong strategy. And we may need to rethink kind of how much ATR inhibition we need, especially in these patients that already have PARP resistance, to really get that synergy. And the same is true for WEE1 and ATR combinations. Those preclinical studies are going on right now too. In the interest of time, I couldn't show those to you, but it's not just about figuring out how much of one drug you can add to full dose PARP. There is going to be some magic in the amount of the other drug, the replication stress drug that you need, and potentially the sequencing. And so we're starting to figure that out now. So in conclusion, what I would say is, number one, incorporation of reversion mutations and homologous recombination DNA repair genes for patient selection or as stratification factors for future PARP inhibitor clinical trials, or even any study with the DNA damage response pathway, is just critically needed. This has been missing from a lot of our studies, and we have abundant data now to show us how important it is. Mechanistic understanding of acquired PARP resistance, PARP inhibitor resistance, which is likely multifactorial, is critical in designing trials for these patients. So maybe olaparib cediranib is a useful strategy for a subset, and we just didn't enroll any on that trial. So really understanding what mechanisms are at play and how we identify patients to go on the right trial is really complex. That's actually what we're doing now. And so that's pretty exciting. And I just think this was such a small smattering of samples, have like an hour and a half worth of slides to share, but the quality of science that has been done preclinically and the quality of the phase 1 studies that are being designed as a result is so high level that you really should feel encouraged, and our patients should feel encouraged that we are going to solve these problems of resistant tumors and help them keep going, keep improving those incremental progression-free survivals, and keep pushing out our overall survival until we can figure out how to cure this thing. And with that, I thank you for your attention, and I'm happy to take questions.